Hi,
Hi,
here's Snježana and Mia.
and today's topic is
Partial extraction therapy.
Yes. So maybe you are familiar with it. We hope that you are not, because then this episode is just for you. We want to make this technique more approachable for you, and that you become more interested in it. Because although it has been done for over 10 years, it is still considered as a novel therapy. Its acceptance is growing. There are more and more clinicians utilizing partial extraction therapy, but still there is some resistance to it. So let's start from the very beginning. What is partial extraction therapy?
Partial extraction therapy, it is like it says, it is a partial extraction therapy. The tooth, a diseased tooth is not extracted in total. Parts of it are left behind, but not randomly and intentionally. They are left behind. Why? And which parts of the tooth? What we know from the general surgery, if an organ is diseased, if let's say pancreas has a cyst, no one comes with the idea to take out the entire organ. Surgeon is going to cut out the cyst and to save what still functions. And this is with teeth. If the periodontal ligament of the tooth, and everything here in partial extraction therapy is about the periodontal ligament, if the periodontal ligament is healthy, then the buccal lamella, the root membrane, the socket shield can be left in place. Why? To maintain the rich contours, because after the tooth extraction, the major problem is the buccal bundle bone. The buccal bundle bone is completely tooth-depending part of the jaw, of the ridge. And when the tooth is extracted, then it's going to resorb. So when we leave a part of the root, the lamella, then with the periodontal ligament, a periodontal ligament is one of the major sources of the blood supply to the buccal bundle bone. So the buccal bundle bone is nourished and it's going to survive. It's going to be really very, very little rich resorption when the partial extraction therapy is done. Huerzeler came with socket shield with this idea. He published proof of principle in 2010, but partial extraction therapy is older, is more than 50 or 60 years old. It started with the root submergence therapy. Okay, now I mentioned already root submergence therapy. This is one of the forms of the partial extraction therapy. We do have a socket shield with immediately placed implant, socket shield with delayed placed implant. We do have a root submergence therapy, and there is also a Pontic Shield.
Often clinicians are asking, why should we take a risk in doing such a new therapy, novel therapy? If we do have techniques for bone augmentations and they function pretty well. So, and they do preserve the socket. Why would they?
Do they really work that well? What do you see in your cases, in cases of your colleagues, and also what this literature says? Prospective, retrospective studies, literature reviews, evidence-based medicine. There is no grafting material that can maintain the rich dimensions after the tooth extraction completely, and it is only partial extraction therapy that maintains the rich dimensions almost completely. If we were happy with our cases long-term, we wouldn't do any novel techniques. It's not only because we want to be pioneers. It's always, I remember the case of one colleague, one friend of me. He posted X-ray from the single molar implant placed 6 years ago, and on X-ray, two-dimensional X-ray, everything was fine. He got so many likes, so many loves. I mean, is this what we promised to our patients? We are going to place the implant for so and so many $1,000, euros, and you have
it will look good on the X-ray.
And if it looks in 6 years good on X-ray, we are going to be very, very excited.
But if that technique is so great and everybody is that is doing it are so enthusiastic about it, why the acceptance is so low?
The resistance is also maybe because of few papers that were published. The papers reporting about implants placed in contact. Now listen, implants placed in contact to unintentionally retained root fragments. Okay, someone extracted the tooth, and the tooth had some periapical area, vertical root fracture. Many cases that are shown in these two papers are with the vertical root fracture. It wasn't diagnosed. Implant was placed in the close proximity or even in contact with this unintentionally retained root fragment, and of course the patient developed complications after a few months or after a few years. And it is, of course, I agree with this 100%, but the authors concluded, that there is a raising interest in the partial extraction therapies, or there is a raising interest in living intentionally the root parts in order to maintain the rich dimensions, but it is very risky. Don't do it. You can see what happens if it is done.
I admit there are long-term studies, even one with 10 years follow-up. But it can be objected that it's not enough data to tell for sure that one technique can be backed up, but from scientific and practical point of view.
We do have really, you mentioned already, 10 years follow-up, 5 years follow-up, up to 4 years follow-up, very, very honestly, with all complications that can happen. And we do have very nice clinical trials, prospective randomized studies showing partial extraction therapy superiority compared to the standard conventional post-extraction implant placement without socket shield. But I'm also long enough in tooth business to understand the skepsis. We were enthusiastic, we were euphoric many times, first with the post-extraction implant placement, and then Joseph Kahn has shown that the recession happen often. And we have learned how to place properly post-extraction implants with gap and small diameter implants and connective tissue and immediate provisional, okay. And it became absolutely better. And also Huerzeler was very honest with his full arch cases. His first full arch cases, like my full arch cases, were this minimally invasive post-extraction implant placement without flap elevation, with filling the gap. And it works nice, it looks good for a few years, and then the problems start. So nowadays, for full arch approach, I like Simon Pieri approach for full arch cases with implant placement and really nice thick veneer grafting and flap elevation, of course, in order to do this. But I still think that the partial extraction therapy is different because the biology explains it. because in partial extraction therapy, the part of the root with periodontal ligament is retained. And this periodontal ligament is supplying the buccal bundle bone, but not only the buccal bundle bone, the interproximal bone, and very important, the peri-implant soft tissue, the peri-implant connective tissue is supplying with the blood. And this makes a difference. This rich maintenance, and we are many, and we communicate very, very close and very honest in our partial extraction therapy group. None of us have ever seen a case of peri-implantitis with partial extraction therapy. We have seen, of course, different scenarios of complications and failures, but never peri-implantitis.
Have you seen the complication like shield loosening?
Yes, complications like shield loosening. I've seen it twice in my patients, and each time why it happened, it was because the shields were too short. When the shield is prepared too short, it doesn't have sufficient stability to survive, and then we can see shield loosening. It is also the shield displacement if the cervical area, the transgingival area is not prepared properly, and the abutment or the crown is doing a pressure on the shield. Then we do see complications, but we have seen complications more often 10 years ago. Now the protocols are developed, and I can really advise you to read Gluckman, De Toa, Salama paper, 10 years. We will put a link underneath this video or podcast, how to prepare socket shield in order to avoid complications. Also in the book from Udatta Kher and his co-authors is described very nice. It is important to follow the rules, to follow the PET rules. It is not only about the technique, it is also about indication, of course. Not only about the shield thickness and the shield length, but also about indication.
What are the indications and contraindications? Yes. I can imagine there are contraindications.
Yes, this is almost a better question to start with contraindications than with indications. What do we need? We need a healthy tooth root membrane, a socket shield with a healthy periodontal ligament. What does it mean? It means that the tooth shouldn't be periodontally diseased, no mobility of two or more. It means also that it shouldn't be any internal or external inflammatory root resorption of the buccal root part. It also means that the root canal content should be removed, and also the apical area should be removed. It is basically the therapy for the teeth with intact buccal bone, with intact periodontal ligament, with tooth mobility less than 2. And then one would say, you never see it. You see it very, very often. It's not only the teeth with horizontal fracture. These are our patients that come, with 20 years old bridges and crowns, and we take it down and cannot do prosthodontic therapy on it. These are also the teeth with unsuccessful endodontic therapy. It is very, very often that we can apply a partial extraction therapy.
Let's talk about the technique. You already mentioned and we discussed about the socket shield, but partial extraction technique is not only socket shield, it is also root submergence technique.
Yes, root submergence technique. Many clinicians that start with partial extraction therapy, they start actually with root submergence technique. And when they do hands-on on socket shield, on partial extraction therapy, we always start with root submergence therapy. And you wouldn't believe, you will believe because you join me in my courses, that there is really such a big problem in the minds. They hardly ever submerge sufficiently the root. Yes. Okay, root submergence therapy first, what does it mean? It means that the coronal part of the tooth is basically cut off and the root is submerged. Of course, this root must be
healthy.
It can be a vital tooth or with the proper endodontic treatment. Yes, proper endodontic treatment. Just imagine, it must be a root that you would take to do a new crown on it if you had a coronal part of the tooth. This did we use for the root submergence technique. It was developed in 60s and 70s in the last century already, when the clinicians noticed when the roots remained in the ridge underneath the prosthesis, that there was less or almost no ridge resorption and better hold for the prosthesis. And in 60s and 70s, not only case presentations were published, but also the animal studies were done, clinical studies were done, also human histologies were taken. Human histologies showing that mostly the bone or the connective tissue, of course, both of them cover the root after this procedure, a few months after this procedure. But no connective tissue and no bone, of course, will cover a root if it's not submerged sufficiently. It must be submerged in that way that the margins of the root adjacent to the bone are on the bone level, and then the root is concave, it's hollowed out to make a place for the at least 3 millimeter soft tissue coverage between the submerged root and the pontic base, because nowadays we utilize root submergence technique for the pontic sides. This is how this procedure that was published and utilized 50, 60 years ago became again popular when Salama and his group published amazing case with the submerged root between two implants in a static area. And Salama had recently shared in our group 10 years follow-up of the case. It looks still amazing.
But sometimes we can't do root submergent therapy. When it's not possible, if there is some kind of inflammation,
if there is periapical area,
periodontal pocket on the palatal or the lingual side.
Yes, yes. This is if there is periodontal pocket on the palatal side, if there is a periapical area, if the tooth doesn't have a proper endodontic treatment, non-vital tooth and not proper endodontic treatment, we cannot do root submergence procedure. We shouldn't do it. But what we can do?
We can do Pontic Shield.
And what is the Pontic Shield?
Pontic Shield, it's it's like socket shield, but even easier because no implant is placed.
Yes, it is simply socket shield. Yes, and now we can go through the steps of the socket shield preparation. or not through the steps of the socket shield preparation, because for this one needs really some video assistance to show it. But just to emphasize what we want to have at the end. We want to have a healthy piece, a plate, a shield of on the buccal of the root. It must be long enough to have sufficient stability. And now you can talk about the 2/3 of the root length, or about at least 6 to 8 millimeter of the length, in order to get the sufficient stability. And it should have some thickness, of course, about 1.5 millimeter, to avoid any flexibility of the socket shield. And it is very, very important to remove root canal content.
Any organic.
Apex, yes, any organic parts of it, apex, periapical areas. We can add apicoectomy. I do it often with socket shield therapy to make sure that I really removed all periapically diseased tissue. And these are the major points of the socket shield preparation. And there are instruments to do it, drill sets. We can put some links below the video.
So now we prepared the socket shield, and the implant should be placed. So what are the rules for it?
The rules for it depends which implant system or which implant abutment design one utilize. The majority of clinicians nowadays utilize implants with the conus connection, platform switched implants, and implants should be placed about 1 millimeter below the socket shield level. I have forgotten to mention that socket shield should be prepared to the bone level, on the bone level, and very important is to thin out the socket shield in the coronary area. Why? We place an implant 1 millimeter below the socket shield, and then already our abutment comes out, and we need about 2 or 3 millimeter space again for the soft tissue coverage between prosthodontic components and the socket shield. And implant is, of course, placed prosthodontically driven. It is placed mostly, almost always, in the palatal part of the socket. It is, of course, the best thing you can do is to guide your implant placement. And it is also possible to, I will say, semi-guide a socket shield preparation, just cheating, just tricking the implant navigation software and telling, I want to place my implant actually in this area where we want to have our first drill. It is through the root canal to prepare the socket shield.
So we are now familiar with the socket shield, buccal socket shield, which is a line-to-line angle, but there are some variations of the socket shield, like C shape, L shape, proximal socket shield.
There are some variations, and yes, sometimes you want to ask about necessity. Yes, sometimes they're really necessary. Joseph Kahn published the proximal socket shield. And what for is the proximal socket shield? Proximal socket shield is important if an adjacent tooth is not a tooth with the periodontium that maintains the bone peak between implant and the tooth, but adjacent to our implant that we need to place is an implant or edentulous area. So it is important then to maintain the best we can have this interproximal tissue. And if Imagine if it's the root fracture in the buccal-palatal dimension, then we cannot prepare a standard socket shield, but we can still retain what's healthy. This is like Chuck Swimmer says, keep the good, lose the bad. Yes. And then the proximal shield can be prepared. Or if there is root resorption on the buccal part of the root, but not in the proximal part. Otherwise, we can prepare L-shaped socket shield. It means socket shield on the buccally, and with extension interproximally. Or C-shaped socket shield. This is socket shield that has extensions towards the mesially and towards the distally. This C-shaped socket shield is not only for the situations with the adjacent edentulous areas, but it is also when, let's say, because of the big periapical area or because of the previously orthodontic movement that results in very short roots, and we cannot retain 6 to 8 millimeter of the buccal socket shield, but we really desperately need socket shield in order to maintain the ridge dimensions, then it's very logically to extend the shield surface. And how to extend the shield surface, but by extending it to the mesial and distal area. So these are then indications for the L-shape, C-shape, and proximal socket shield.
When you place the implant, there should be, or sometimes it remains bigger or smaller gap toward the socket shield. So do you graft it or you don't graft it? Is it necessary? It's not necessary?
Yeah, it's a good question, and nowadays we still don't have a proper answer. But let's go just a little bit back to the first part of your question. It was you told sometimes there is a gap. Actually, we should strive. We should tend to have a gap between implant and socket shield. Why? Because when an implant is placed, it can happen that the socket shield gets displaced or fractured through the pressure by during the implant placement. I faced it once in my career, but it can really happen. For this reason, it is better to have a gap. Not only for this reason, it is also to have a sufficient space. I already mentioned this space for the soft tissue in the coronal part of the socket shield. So it is better to have a gap between implant and socket shield. It is possible to do it without a gap, but it is more safe with a gap. Okay. And regarding grafting the gap, there are some animal histologies that we have, and all animal histologies are showing actually socket shield in the direct contact to the implant. And they displace a bond between implant threads. There is a bond between socket shield and, not between socket shield and implant, but there is a bone growth or between implant threads. Animal histologies. Two human histologies we have. One from Chuck Swimmer, showing a bond between implant and socket shield. Again, implant is in contact with socket shield, and from the Greeks group, showing 3 millimeter soft tissue ingrowth in the coronal part that was not in the contact with socket shield. So there are different groups and approaches in the partial extraction therapy world. Some of them grafting, some of them not grafting. It is interesting that we really have predictable, nice and stable results, but we really don't know what happens in this space between implant and socket shield. Histologies that are available are showing the bone. But in some CBCTs, when we look at the CBCTs, we are not very sure. Where we can look into the healing, into the tissue that grows inside the socket is in the cases when we prepare the socket shield, but we don't place an implant immediately, but delay implant placement. Then we can really see what kind of the tissue is built inside the socket. But it is the topic for another episode about the GLOKA technique. GLOKA technique means
leaving the socket shield without implant placement, but grafting the socket, but grafting
or not grafting the socket.
Yes.
And coming back delayed to place an implant. I've done a retrospective study to this topic, and we are going to talk about it. This is the topic I am the most passionate about it.
Stay tuned.
Bye.
Bye.